Hello. Looks like I'm the only thing standing between you and lunch, so I'll try to move this along. And I usually talk fast, so that'll help too. So I decided to talk about the limping child. I'm Ryan Hartman. I've been at OCR for, I think I'm at my 14th year there. And I have kind of a mixed practice. I do about 30% of my practice as kids, just all types of pediatric orthopedic things. And then maybe 70% of my practice is adult knee and shoulder. So I did a sports medicine fellowship and I did a peds fellowship. And so I kind of combine that. But I get a lot of questions about, what makes a child limp? And so I get questions sometimes from pediatricians or family practice doctors or referrals and also from physical therapists. And so this is part of this talk I think I did give maybe 7 or 8 years ago. I kind of resurrected it, added a few things, and thought it would be a good one to go through. So I will leave some time for questions at the end, but as we're going through it, I'm certainly happy to take a question. If something comes up and you're like, hey, what about this? While we have a slide up, I'm happy to try to answer something. So I just want to talk about kind of normal, abnormal gait patterns. How do we work up a child who's limping? And then talk about some common conditions that can cause a limp and how do we go about treating some of those things. And so in order to talk about abnormal gait, it's good to talk about what is a normal gait. And so a normal gait cycle goes from a heel strike of one leg until you get back to the heel strike of that same leg. And this is just kind of a depiction of the gait cycle. But if you look at when we walk there's always one foot on the ground unless you're running. When you're running, then there's a time when there's no feet on the ground. And so the stance phase is about 60%, and about 20% of the time you actually have both legs on the ground. And then the swing phase is the other 40%. And you have to have a certain number of muscle requirements for, to be able to walk, right? You have to have a stable pelvis. You have to have hip flexors and to be able to get your leg off the ground and clear your foot. You have to be able to have deceleration when you slow down so that you don't just fall forward. And so there's a lot of coordination between nerves and muscles and bones and joints to make us be able to walk. And it's obviously something we do without thinking about it. But when it comes to pathology, there's lots of places along that chain of events that can go wrong to make somebody limp. And so if you look at a child that first starts to walk, they often walk with a really wide-based gait. They're kind of like a drunk person. They want to have a stable base, and so they're very wide-based. And they often will have one leg that feels more dominant to them than the other. So a little kid that starts to walk will often turn one leg out to give themselves a wider stance. They'll kind of drag that leg behind. And by about age 2.5 to 3, most of that goes away, and they start to walk like a normal human. But there's still some changes to gait that aren't really done until later. Most children by about age 7 kind of walk like a really normal adult. And then as we get older, it starts to go the other way where we spend, the gait slows down, there's less time, or there's more time in double limb stance because there's more need for balance and stability. And so these change over time. Also, just a couple comments about alignment of the legs, because I get a lot of questions about this. I get a lot of children that are referred for, bow-leggedness or knock-kneed or in-toeing or out-toeing, and I have a section at the end of the talk about in-toeing and out-toeing. But if you look at alignment to angular change of your knee, when children are born, they almost always have a little bit of a varus alignment, which is bow-legged. And then as they get to about age 3, that will change to a little bit more of a knock-kneed alignment. And most kids don't get their adult knee alignment until about age 5 to 7. And so they kind of go through this little thing. And not every child goes through dramatic changes. Sometimes it's very subtle. But there are a lot of little babies, if you really look at them, they'll have a little bit of a bow-legged alignment. And there's a ton of 3.5, 4-year-old kids that look a little bit knock-kneed. And then when they get to about age 5 to 7, they get their adult alignment. And so other than there's a few conditions, which I think I have in here later, we don't get too worked up about some subtle changes with alignment until they get about kindergarten age, and then we start looking at it in a more detailed way to see, hey, is there something going on that's not normal here? So reasons for an abnormal gait. Sometimes it's pain, sometimes it's weakness, sometimes it can be leg length inequalities, and there are other things too, but these are kind of 3 common things. So abnormal gaits, there's 2 broad categories of abnormal gait. One would be an antalgic gait. That's a painful gait. That's what causes a limp many times. And when you have an antalgic gait, you have a shortened amount of stance phase time on the limb that hurts. You're trying to clear that limb and get it back off the ground and get on your other good limb. And so that's kind of the definition of an antalgic gait. And then there are multiple types of non-antalgic gaits, types of limps that aren't due to pain, they're just due to other things. And so if we think about what would cause a child to limp by age, In the children that are under 4, we see things like toddler's fractures, bone infections, foreign bodies. Sometimes those are missed, and somebody comes in with limp and you start looking and they have something in their foot that actually was what was causing it. It wasn't something worse. And congenital hip dislocation is a very sad one, but I see probably 1 or 2 of those every year where a 12, 18, 20-month-old kid comes in with a limp and we find out that they have a hip's been dislocated since birth. We just found it. So if you look at the 4 to 10-year-olds, they can have some of the same things the younger kids can have, but we start thinking about other things like Perthes disease, OCDs, and those are often in the knee. Sometimes they can be in the ankle, other places, but the knee and ankle would be the most common. Discoid meniscus can sometimes cause swelling in the knee in a younger kid and pop and swelling and pain and limp. There's some different types of avascular necrosis in the foot, in the hip, and these can cause limps. And then in the older kids, sometimes we'll see stress fractures with sports. We can see in some of these other conditions I'll talk about more later, but these are, so sometimes just thinking about the age of the child will help us kind of narrow in on what might this be that's causing them to limp. Tumors are a pretty rare cause of limp. There's usually nighttime pain and other things that we think of more than just limp, but certainly that is something that sometimes is on parents' minds. They say, oh, my child's limping, do they have a tumor? And so those are things we always have to reassure patients about. So non-antalgic gaits can be described as these different types, and I'll go through each one of them. I have a slide for, so I won't read through these. But a Trendelenburg gait is a gait that's caused by having a weak hip abductor. And so if you look at this picture, on the one on the right, the left pelvis is up and the right hip is down. And so in this would be caused by having a weak hip abductor on the left side. Normally when muscles are strong, they shorten or they contract, and if that left hip abductor contracted, it would pull the pelvis down on that side and it would raise the pelvis on the other side. And so when you have a weak muscle, that muscle can't shorten or contract, it lengthens, and so the pelvis drops to the other side. And sometimes to compensate for this, patients might lean their trunk to the other side or to the affected side to balance themselves out when they walk. So this is a Trendelenburg gait, and we'll see this with hip weakness. And in children, we can sometimes see this with a missed hip dislocation. We can see this because if their hip is dislocated, it's setting too high, then their muscle's not tensioned optimally. They lose what we call like the Blix curve on their muscle, and so they can't contract it right. And so that will sometimes cause them to limp. Perthes disease is a cause we'll see in children like 4 to 8 years old is kind of the main age, and I'll go through that later as well. And then sometimes in heavier children, we'll see SCFEs or slip capital femoral epiphysis. Sometimes with neurologic things like hemiplegic cerebral palsy, we'll see kids that have a limp from that, and then they'll have a Trendelenburg type gait. Sometimes they have a crouch gait, and I have some other slides on that later too. Circumduction is more when they try to kind of clear the leg around because it's too tall or it's too long. So we'll see that with more leg length discrepancies. We can sometimes see it with other things as well, but I'd say that a leg length discrepancy will cause a circumduction gait most often. And then a vaulting gait we'll sometimes see. We can see that with different weaknesses where they're trying to push themselves off and vault over the top of their next step. And we'll see that sometimes in side-to-side differences in muscle strength, like in cerebral palsy. Sometimes when kids are toe walking, they have really tight heel cord on one side. It makes them feel longer, so they have to vault and get across over to their other side. And then, again, leg length discrepancies can cause that as well. A steppage gait, this is more neurologic often. We see sometimes kids that have like Charcot-Marie tooth, or again with cerebral palsy or other muscle weaknesses, and they're trying to clear their foot before it slaps down to the ground because they can't decelerate and they can't slow their foot down from stopping. And so that's another one that we see probably less often, but it can be in the mix. Equinus, this is one that I see a lot. We have a lot of kids referred for toe walking. And I would say probably the most common cause is actually habitual toe walking. We see kids that just get into a pattern of toe walking, and sometimes it can be associated with sensory processing disorders, or it can be associated with some kids that have, I'm blanking on it, like autism. Some kids are autistic will toe walk actually because they have these, for some reason with their sensory processing disorder and autism, they'll have a lot of toe walking. I see a lot of kids that have that. And then sometimes if they do it for long enough, it can lead to more pathology where actually they get a tight heel cord and they have other more physical things that then we need to try to reverse. And so I have I think in one other section later I have some more details about how we go about actually treating toe walking. But toe walking is a very, very common thing. A lot of times, kids will do it just out of habit and it'll go away. But later on I'll explain more about how we actually figure that out and how we go about treating it. So when you see a child with a limp, the questions I always ask myself is, was there an injury or not? Did this start suddenly from something that hurt the child, or was this just something that has kind of always been there and now we're just finally kind of noticing it? And then, with toddlers' fractures, if they won't walk, will they crawl? And that helps us figure out, if they won't walk, but they'll crawl, it's probably not in their femur or their hip, it's probably in the lower leg. And then are there, any wounds like for foreign bodies? Do they step on something, they have a needle in their foot, they have a toothpick in their foot? You got to kind of think about those things. These are 5 questions I always ask myself. Is the limp due to pain, or are they just limping because they're limping? Did it start suddenly, or has it always been there? Are they ill? Is it something like a bone infection? Is it a hip infection? Is it discitis? Is it something that's more like systemic? And then what type of limp they have, going back to those limps we went through, what does their gait look like? And then, can we localize the problem? Sometimes in pediatric medicine, it's kind of like veterinary medicine. The patient can't always tell you what's going on. You have to rely on the parents. What have their observations been? Or you can't always rely on the kid to come and tell you, hey, I'm limping because my foot hurts, because they sometimes don't know, depending on the age, obviously. And then this is kind of what I was just highlighting, but the history is often from the parents, and then we go through all these, timing, and that will kind of help narrow in on what their diagnosis might be. And then fever is another thing which I'll talk about with infections, because generally if they have osteomyelitis, if they have a septic joint, if they have discitis, they often have fevers related to that. So with the exam, when I examine children with a limp, I always try to get their pants off. Obviously, in older kids, we'll get them in shorts, and they're just really little, we'll just leave their diaper on. But we usually have them walk. So I usually get them up off the exam table, I have them go walk out in the hall. Because there's a lot of things you can pick up when you see them walk that you can't just, if they don't have a little bit of room to go. And sometimes I'll get them to run, or sometimes I'll get them to hop on one foot. And partly they enjoy that part of the exam, but it also gives me a lot of information. And then standing, I always look at their alignment. What's their alignment like? Is their pelvis level? Do they have, are they trying to get their foot up off the ground? Are they in, do they have knock-kneed or bow-legged? Is there asymmetry between the two sides? And then I'll see if they can rise up on their toes. Can they walk on their heels? And that gives me a lot of information about strength and, what muscles are working, what muscles aren't working. And then I'll set them on the exam table, and I'll take a look kind of from their toes up to their hip, and I'll just start, moving different joints and checking their flexibility of their joints, checking their strength. Do they have any flexion contractures? Is one side tighter than the other? I'll check reflexes. I'll check for clonus. We'll see, is this neurologic? And you can get a lot of information by just going kind of toe to hip and examining them. And then on the tabletop, at the end of the slide, I'll talk more about rotational profile and how do we look at kids that have either maybe tibial torsion or femoral anteversion, because I get a lot of questions and referrals for what's in-toeing, what's out-toeing, and how do we figure out where it's coming from. And so I have a whole little section on that here coming up. So imaging, we almost always start with x-rays. I don't x-ray every child with a limp, but it's not uncommon that after we've done the exam, then we'll go back and say, okay, I'm concerned about this body part, let's get an x-ray. They're readily available, they're fairly inexpensive, and they can give us a lot of good information. And you'll see later some of the conditions we go through. I have x-rays to show, what you would see on those conditions. And then ultrasounds can be helpful for hip effusions in kids, sometimes with, looking for septic hips. But otherwise, I would say I don't use ultrasound very much. Bone scans I rarely use anymore. I think those were, in the past, they were used a lot more often. I think more often now, we're probably a lot quicker to go to MRI. The downside of MRI in kids is that if they're under about age 5, they can't get an MRI without sedation typically. And so then that introduces a whole new, question, is it worth getting information on the MRI by sedating the kid, or can we figure this out an easier way? So that's always a question we ask. So lab work, this is not certainly something we get for every limp, but in some limps, if we're worried about more of an acute infection, obviously we would get lab work. And sometimes if we're worried about more like rheumatoid arthritis or some sort of an autoimmune inflammatory arthropathy, blood work can be very helpful for that. And so in a minute here, I'll show you a slide on, there's something called the Kocher's criteria that can be very helpful to figure out, is a limp due to an infection, and lab work is usually part of that. So the CBC is something, it's not super sensitive or specific, but it can be helpful sometimes in kids with osteomyelitis. ESR and CRP are obviously a little bit more helpful to look at inflammation, but those are also not very specific to anything. They can be up in autoimmune problems, they can be up in infections, and so they're helpful, but they're not necessarily always diagnostic. And then joint aspiration, if we're worried about infection, we'll obviously get fluid out of the joint and send that and say, hey, is there bacteria in here? What's the cell count look like? What do we see in this joint fluid? And then if I think that they might have some sort of an autoimmune problem, we'll get a whole panel of tests. We'll look for a rheumatoid factor and ANA to look for lupus-related conditions. We'll look at HLA-B27, which is to look for like ankylosing spondylitis. Anti-CCP is another way you can check for rheumatoid. The problem with kids is that in children, only a small percentage of them actually will always have positive lab tests. You can have, a lot of kids will have JIA, and up to 20% or more of those kids will not ever have a positive lab test, but they'll have all the clinical symptoms that go along with it. So that can be very, very frustrating sometimes. And then these are the Coker criteria I was referring to previously. So if we have a child, and this is a lot of times I'll get calls from the ER, and they'll say, hey, we have a kid that is limping, and we think they might have a septic hip, and we go, how do we figure out, is that septic hip or not? So the 4 things I ask is, can they bear weight or not? Do they have a fever? Do they have an elevated white blood cell count or elevated inflammatory markers on a SID or CRP? And it's interesting, if they have only one of those is positive, there's only about a 3% chance that they actually have a septic joint. If you have 2 that are positive, it goes up to 40%. I start perking up if they have 3 or 4, because if they have 4, almost every time it'll be an affected joint. But even if they have 3, there's the 3 out of 4 chance that they have an affected joint. And so those are the ones that obviously are probably going to need to be taken to the operating room and washed out, or at least aspirated to confirm. So now I'm going to go through some conditions, and I have just a whole bunch of slides, kind of one slide on each condition. I won't spend a lot of time going through each of them, but these are all different things that can cause a limp and things that we see. So Perthes disease has a male to female preponderance like 4 to 5 to 1. So you see a lot more boys with this than girls. And if the age at their diagnosis is really predictive of how well they'll do. If they get it when they're young, they do great. And if they get it when they're a little older, they don't do so well. And so most of the time it's unilateral. Occasionally, like 15% or so of the time, it can be bilateral, but usually they won't even be at the same stage. They'll get it in one side, then within a year or 2, they may get it in the other side. But Perthes disease is just basically like collapse, avascular necrosis of the epiphysis of the femur up at the top, and then it goes through this big course of remodeling. It takes a couple years for it to resolve. Another one would be toddler's fractures. I see lots and lots of these. One of the most common mechanisms will be a parent will have a child in their lap, they're going down a slide, and the kid catches the side of their foot on the slide and twists it, and all of a sudden they cry, and then they won't walk anymore. And so they come in, and they're limping, and it goes on for 2 or 3 days, and they just won't walk, and they come in, and we get an x-ray. The problem is that about 30 to almost probably, I would say 50% of the time, you won't see a fracture on x-ray, but they'll have bone tenderness at the site where the fracture's at, and the tibia is by far the most common. We see other areas as well, but the tibia is by far the most. And I usually put them in a cast for 3 to 4 weeks, and usually within 2 or 3 days being in the cast, they'll be running around. We bring it back, take the cast off. I don't always re-x-ray them. I kind of work it out between the parents and what our suspicion level is whether we x-ray when the cast comes off, because most of the time by then they're doing well and they're non-tender and they're walking, and I think an x-ray is just, it's a waste of radiation on the kid and it's a waste of money for the parents, and so I don't often re-x-ray these. But toddler's fractures are very common. Skiffy, so these are typically in later childhood, early adolescence, and we see, there's a little bit more boys than girls. Often these patients are overweight, and what's happening is that they have almost like a stress fracture through the growth plate at the top of the hip, and it's like the ice cream falling off the cone. It starts to rotate out to the side and off the back. And there's been some change actually in treatment in skiffies over the years. As it used to be that we just pinned them where they lied, and we just went in and put basically a screw across it to hold there until it healed. And I think that's still a good treatment if they're very minimally displaced, but if they have a big slip angle, there's been a big increase in actually opening those hips up and trying to reduce that and fix it, because their outcomes aren't great if you leave them with a very slipped hip. They really lose their internal rotation. They end up with an externally rotated hip, and they progress later with arthritis, and they have a lot of troubles. And so this is one where we try to catch these early. Sometimes these can be acute and sometimes they can be chronic. They're more often actually chronic, where they just start to develop a limp, and often they'll come into clinic complaining of knee pain. But if you see a heavy kid and they're 10, 12 years old and they're complaining of knee pain, it's always good to check the hip, because you might miss one of these otherwise. Another one would be leg length discrepancy, and these can be caused by lots of different things. I would say the most common would be just, some people are just born with legs one size different than the other, and there's been a lot of studies done on this. There's some big military recruit studies that they've done, and about 30% of the population has about 1.5 centimeters of leg length discrepancy. So generally, if the discrepancy is less than 1.5 centimeters and it's not causing symptoms, we don't do too much about it. But if the discrepancy gets to be 2 centimeters or more, there are fair numbers of studies that will show that can actually cause back problems, hip problems, and other functional problems. And so then we start thinking about doing things to level that out. And if they're still growing, and I have a whole separate talk, maybe sometime I'll do on that, but there's some guided growth things we can do to actually slow growth plates down on one side and let the other side catch up for both angular and length deformity issues. But for most leg length discrepancies, we follow those over time, and if we're going to project that at skeletal maturity they're going to have more than a 2 centimeter difference, then we will treat those. And so again, it'd be a whole different talk, but leg length discrepancy is something we see a lot of. Toe walking, so this is where I want to spend a couple minutes on this one, because this is super common. I think the most common I see is just habitual toe walking. The kids they start out a habit, and it's just hard to get them to stop the habit. It certainly can be due to other things, like we see it with cerebral palsy. We can see it with leg length discrepancies have been not recognized, and so one leg's longer and taller, or and so they're limping or they're toe walking because of that. But I would say the biggest thing I do when I see a toe walker is I try to determine, is the heel cord tight or not? Like, can they still get their heel down on the ground or can they not? And then if they can, then there's a different kind of set of treatment than if they can't. And so if I see a child that they can't get their heel on the ground, then that tells me their heel cord's too tight, and we're going to have to do something to loosen that up. So one of the first things we'll do is we'll do serial casting. We'll bring them in, and we'll lay them on their tummy, we'll bend their knees up, and we'll dorsiflex them, and we'll cast them with a plantar flexion or a dorsiflexion stretch on their foot, and then I'll change that cast every 10 to 14 days, and we'll do 2 or 3 in a row. And each time we take the cast off, we measure and we say, hey, did we make any room? Did we make any headway? And if they're not making any headway, then maybe a child that might need their heel cord lengthened, which I'd say is pretty uncommon, but occasionally we actually go lengthen the Achilles or the gastroc muscle. But often, if these kids are just little, they're 2, 3 years old, they've just kind of started toe walking kind of for fun, the little kids will get up on their toes. We observe that, and if they don't have a tight heel cord and they just kind of break the habit, it's not a big deal. And then sometimes they'll come in and they will have their heel cord is fine, it's stretched out, they can get their heel on the ground, but they just have this bad habit of it, and they've tried therapy and they've tried different things, they just can't break the habit. That's when I'll go to using a daytime AFO with a hinge in it and a plantar flexion stop at 90, so they can't plantar flex, but they can dorsiflex, and it helps them try to unlearn this habit of toe walking. And then at night time out, if they have a tight heel cord, I'll sometimes put them in a brace that looks like this to help stretch their heel cords at night. And almost always combine treatment for toe walking with physical therapy. I think it's super helpful for them to come to therapy to see how to stretch out their heel cords, how to stretch out their gastroc, and then these different cues and reminders to help them get off their toes. And so this is a thing we see a lot of. And I think that if I go to the bracing like this, where they're using these in the daytime, I'll typically keep them in those for about 3 to 4 months. And if they wear them really consistently for 3 to 4 months, that will usually help them to unlearn that habit of toe walking. So I find that to be pretty effective. These are always sad to see in clinic, unfortunately, like I was saying earlier. I'll see 1 or 2 of these kids a year where they come in and they'll be between a year to usually 2 years old, and they'll have a limp, and we start to do the exam, and the biggest thing you'll notice on exam is one leg will look shorter than the other. You'll go to flex their hip and abduct them, and they'll have asymmetric abduction, and then we get an x-ray and they have a missed hip dislocation. And if you catch these when they're really young, there's bracing and options, and sometimes you have to take them to the OR and reduce their hip and cast them. The problem is by the time they get to these ages, a lot of time it's more of a surgical thing where you have to actually reduce the hip, and sometimes in more significant cases you actually have to shorten the femur because everything's too tight. You can't get it in without shortening it. So these are always sad to see. And I think that the pediatricians in general are much much more aware now, and the screening process has gotten a lot better. But if we have, these are the risk factors for hip dysplasia: female, firstborn, breech, and family history. And so if they have 3 out of 4 risk factors nowadays, most all the pediatricians will get ultrasounds and screen them around 6 weeks of age to just make sure we don't miss these. JRA, JIA, I talked about this a little bit earlier, so I'll probably skip over that one. This is probably, I just say the biggest thing with this is typically if they have an autoimmune inflammatory reason for the limp, they usually have joint swelling. So if there's a knee that's swelling, that is when I would more go down this road if there's not anything else obvious that's making that knee swell. Osteomyelitis, bone infections, these just very normal healthy kids will sometimes have a bone infection. I'll see a few of these every year. Usually they are consults that come through the ER, but there'll be kids that are between age, as young as 2, 3, 4 years old, and sometimes as teenagers, and they'll just have onset of like bone pain, fever. Sometimes they'll be a little bit red around their joint, and in their growth plate, there's some tortuous vessels, and the blood kind of swirls in those vessels in the metaphysis of the bone. So these infections almost always start in the metaphyseal part of the bone. We see it in the distal tibia, we see it in the proximal femur, we see it sometimes around the knee, and then usually from there they can sometimes see their joint. If we catch it early, we get them on antibiotics. It's usually non-surgical treatment. But if they develop an abscess, we sometimes have to go drain that abscess, and usually we diagnose that by an MRI. ALL, so leukemia, I've maybe diagnosed 4 or 5 kids over the years with leukemia that just come in with bone pain. They have pain in their arm, pain in their elbow, pain in their leg, and we'll get an X-ray. They have just this little bit of periosteal reaction on their bone. They don't have any history of trauma. The pain's getting worse and worse. Sometimes it's waking them up at nighttime. Sometimes they're limping because of it, and then we'll send them for blood work. Luckily the incidence of this is still pretty low. And fortunately, nowadays, the treatment is very, very good. There are some mutations like the Philadelphia chromosome mutations, and those don't do as well. But most of the other kids with ALL nowadays, although it's obviously a devastating diagnosis for the parents and the patient, is that 90+% of these kids actually do really well nowadays. OCDs, these are basically an area where the bone, the subchondral bone under the cartilage starts to break down. And the thought is that a lot of this is due to repetitive microtrauma. Nobody knows for sure, but the subchondral bone underneath the cartilage breaks down. They start to have usually a limp, sometimes joint swelling with sports. And we typically identify these on X-ray. Sometimes in the early phases, you can't see it on X-ray, but you'll see them on an MRI. And depending on how big they are and how there's these nomograms. When I see these kids in the clinic, I have this nomogram that I plot them out on, and it kind of is predictive of what's the chance this will heal without surgery versus needs to have surgery. And if they have an 80% chance or more of healing without surgery, I usually treat them non-operatively. And when I plot them out, and it's based on their width and size and some other factors. But anyway, if they have a low chance of healing spontaneously, obviously, then we have to operate on these sometimes and either fix them, which is the most common thing we do, and about 80% of them do really well. Stress fractures, we talked about those a little bit. CP, I won't go into this too much. This is a whole, I guess kind of a talk in of itself. But the big thing with cerebral palsy is there's this classification system called the GMFCS classification. And a lot of these kids that are down in the level 4 and 5, those kids are very limited, and they're the kids that are in wheelchairs and have had lots and lots of surgeries over their lifetimes to try to keep them so that parents can move their hips to do hygiene, and they can, they're very involved. And a lot of these ones that have been here are kids that are pretty functional, but they'll sometimes need physical therapy and bracing and stretching and things to keep them functional and active. This is the kind of the last section I have, just to spend a couple minutes on this and I'll be done. But the pigeons and ducks, a lot of people, this is not so much to do with limp, but more leg alignment. So, in-toeing and out-toeing. So generally in-toeing is less concerning because a lot of just this normal developmental things will cause in-toeing that tends to get better with time and growth. And in little tiny, kids and, 1, 2-year-olds will sometimes see metatarsal or internal tibial torsion, and really the young babies will see metatarsal adductus, and those things tend to get better. And a little bit older kids will sometimes see femoral aneurysm. And out-toeing is more likely to be associated with a little bit more concerning things, especially if it's symmetric. And so I'm usually a little bit more concerned about out-toeing than in-toeing, and this is kind of the reason why. So when you examine them, we talk about the foot progression angle, and so when we see a child walk, we say, okay, what's their foot progression? Is their foot pointed outward, which would be an external foot progression angle, or are they inward? Most people walk with about a 10-degree external foot progression angle, just slightly out. And then when I get these kids in clinic, after I have them walk in the hall, I'll put them up on the table and I'll put them on their stomach, and we'll look at their thigh foot angle and their hip rotation to see, hey, is the in-toeing or out-toeing coming from their hips and their pelvis or their femur, or is it coming from their tibia? So if you look at the gait, this is that foot progression angle. Most people point out just a little bit, and this is a graph of kind of age changes over time as to how this changes, but 10 to 15 degrees is kind of about the average out-toeing. So this is the thigh foot angle. So we lay them on their tummy, we bend their knees up, and we draw a line kind of down the thigh and a line down the foot. And this kid would have an internal thigh foot angle. And this is super common in kids that have tibial torsion. And about 35% of kids are born with some degree of internal tibial torsion that tends to resolve by about age 5 to 7. And so that's the thigh foot angle. So if you look at normal rotation, this is just age-related changes this over time. But most kids will be born with a little rotation in, and they tend to untwist on their own. So if I see a kid that's in-toeing, lay them up on the table and they have internal thigh foot angle, and that's all, then I can reassure the parents, hey, by age 5 to 7, this will probably go away, and you won't have to worry about this too much. Femoral aneurysm, this is probably a little bit more difficult, but it can be present in young children, but it can also persist a lot longer than the problem with the tibia. So with aneurysm, we're basically looking at, the neck of the femur, right here, the neck of the femur where the head attaches, that can be pointed forward, neutral, or backwards. And most adults are aneverted about 10 to 15 degrees or so. So maybe a little less than that. As we age, it's less. But with children, they're aneverted more when they're born, and sometimes they're aneverted a lot when they're born. Sometimes kids are like 40 plus degrees. And so to figure this out, and this is just averages. So to figure it out, you lay them on their tummy, and we bend their hip in, and then we bend their hip out. And so if you bend their hip, their feet go out, you're actually internally rotating the hip. And so most kids, when you lay them on their tummy and bend them out, they'll go about 45 degrees and stop, and that's their internal rotation. But these kids are aneverted, they'll go all the way down to the table. They'll go down like 70 degrees. And so when they walk, it's hard to, I guess, maybe just explain this. I should have had one other slide. But when their neck is pointed forward, if their hip is stable, their whole leg has to rotate inward. And that's why they have this internal gait pattern, because their whole leg's inward, because from the hip down, it's causing that. And so with external rotation, you're basically crossing their legs over, and you're seeing how much their legs go. What's the external rotation of their hip? And most kids, a normal hip would externally rotate more than it will internally rotate. And so this is a better picture of it, but that one on the top is looking at external rotation. The one on the bottom is looking at internal rotation. And if you internally rotate more than 70 degrees, we consider that to be probably aneverted. And most of those aneverted kids can sit with their legs in the W position on the floor. And I tell parents with aneversion that it's just a lot slower to correct. They'll correct it some, but in girls it correct up to age 10 or 12, and boys it can correct up to age probably about 14 or so. But it's rarely an operative problem unless it's causing significant functional difficulties. If it is, then we sometimes do an osteotomy to rotate the bone and fix it, but that's obviously a whole big thing. And so a lot of times it's just helpful to be able to, in kids that are in-toeing or out-toeing, to say, hey, is it tibia, is it femur, is it aneversion, retroversion, what's going to resolve, what's not going to resolve. And so if anybody has questions, I could probably go through that a little bit better. But I just want to throw it in at the end because I get a lot of questions about it generally. I think that's pretty much all I had, unless you guys have any questions. Yes?
With the W-sitters with kids, do you typically encourage the parents to get them out of that W?
I don't make as big a deal about that because, so the question is, when you have a kid that's W-setting, do you encourage the parents to have them not W-set? The thing I think about that is how much time out of 24 hours are they really setting in that W position is probably not that much. And so is it really affecting, is it really putting that much stress on their bone that's going to resist them to untwist that aneversion? I don't think it is. Because you figure they're probably only doing that a very small percentage out of 24 hours. So it probably doesn't really keep their hip from correcting with time and growth, if that makes sense. So I think you don't worry about it too much. Other questions at all? Everybody's hungry, right? Sorry, I went through that last part fast. I probably should do a whole separate talk about that someday. Okay, just one announcement then. First of all, thank you for coming. And This is the end of the general session. We have lunch, which I believe is in that ballroom over there. And then it's the same place that breakfast was served. And then take all your personal items with you because they're going to break down this room after everybody leaves. And then the afternoon, there are 4 breakout sessions. And I think the way we have it set up is you can go to 2 of them. And they're on the back hallway in the rooms over there. And so just pick your favorite 2 and go to those. And thank you for coming. And I'll be around if you have questions from the pediatric stuff, or the other presenters are also here. So.